simultaneamente a palestra de Stephen, de modo que não haverá tradução consecutiva. Então, todos vocês vão poder acompanhar a palestra ou em inglês ou em português. Vocês vão poder escolher o idioma, o canal de idioma que vocês vão utilizar. De modo que vocês, se vocês prestarem atenção, vocês vão ver que existe um botão de tradução e vocês não vão poder falar agora, tá bem? Então, não vai ser possível falar agora. Então, caso vocês precisem, digitem para que nós possamos entender do que vocês precisam, tá bem? Depois nós vamos abrir para perguntas e respostas. Mas então vocês podem escolher o idioma que vocês vão poder escutar a palestra, se em português ou inglês. Basta que vocês procurem no menu as opções de idioma original, inglês ou português. Caso vocês escolham por português, vocês vão ouvir a tradutora que vai estar traduzindo consecutivamente. E é muito importante que vocês possam, ao escolher o idioma, vocês podem também desativar o idioma original, de modo que vocês não escutem duas pessoas falando ao mesmo tempo em idiomas diferentes. Então, vocês podem escolher se vocês vão ouvir em inglês ou se vocês vão ouvir em português, tá bem? Então, isso é bastante importante. Vocês podem escolher o idioma, basta que vocês desativem o idioma original, caso não queiram ouvir em inglês, e sim em português. Basta acessar ali e fazer a escolha de vocês a respeito disso. E vocês podem dialogar conosco usando o chat para fazer perguntas, ou ao final do nosso encontro, nós vamos abrir para perguntas e respostas, e eu vou ficar responsável por mediar essa parte. Nós temos uma excelente tradutora nessa manhã, a Maria. Então, vocês vão ouvir Stephen Connor por meio da voz de Maria. É uma bela voz. Stephen vai ficar muito feliz depois de poder ouvir como a voz dele ficou bonita. Eu o conheço bem. Então, sem mais delongas, só lembrando que vocês podem escolher o idioma. Basta que vocês vão em tradução, possam escolher se vão falar em inglês ou português, e que vocês possam, eventualmente, desativar o idioma original, caso precisem. Tá bem? Então, sem mais delongas, vamos ouvir Stephen Connor. Please, Dr. Stephen, you can start.
Thank you very much, Rodrigo. It's good to be with all of you colleagues for this presentation from Elisabeth Kübler-Ross Foundation in Brazil. Rodrigo is viewed by many of us as one of the emerging strong leaders in care at the end of life, particularly, and is one of the foremost foundations for a chapter of the foundations of Elisabeth Kübler-Ross from around the world. So it's a pleasure to accept his invitation to speak to you today. I'll just mention that the Worldwide Hospice Palliative Care Alliance is an alliance of 350 organizations globally in 103 countries that is dedicated to helping advance hospice and palliative care globally. We're in official relations with the World Health Organization and do a lot of advocacy as well as development of services globally in low and middle income countries particularly. So we have a common cause with the passion and the work of Elisabeth Kübler-Ross, who was one of the people who actually helped establish the hospice movement back in the 1970s, and was a champion for hospice and palliative care worldwide. So let's get going. First off, just to understand how big the need is for palliative care. Before the COVID pandemic even began, we typically know that globally over 1 million people die on our little planet each week, around 56 million deaths per year. And about at least around half of those need palliative care, at least. But we also have people who need palliative care before the end of life. So it's actually over 60 million people who need palliative care, if we count those that begin to have palliative care needs a year or two before they actually die. And most of those people live in low and middle income countries. 80% of the need for palliative care is not in high income countries, but it's in low income countries. Unfortunately, about 70% of the current palliative care delivery is in high income countries. So we've really got to, those things reverse. We've got to do more about bringing palliative care into the developing world where the need really exists. And most of those people are older, about 2/3 are older, but we also take care of children in palliative care, about over 8%. The need is for children. We look at levels of palliative care development globally, and we measure those about every 5 years. We've been doing that. And only at present, about 15% of countries really have palliative care well integrated into their healthcare systems. And those, well, there are some exceptions, a number of lower middle income countries that have good integration. The majority of those countries, the 40 countries, are high income countries. And we can't forget that whenever we care for a person with palliative care needs, that includes their family. We can't just care for a person with palliative care needs. We need to also care for their family and help them to care for the person who's affected. At present, only about 10% of the need for palliative care is being met. So we have a long way to go to develop palliative care around the world. And then along comes this COVID-19 pandemic, which is overlaid on top of that need, an additional need for palliative care. As of yesterday, there were about over 5.1 million people who have been diagnosed as having COVID. A couple of million have recovered, but we've had 330,000 deaths. And even in the United States, it's nearing about 100,000 deaths. So we're at the beginning of this pandemic. It's going to continue for a long time. We're going to see much more death and illness. And it's causing some real challenges in terms of how we care for people. Brazil is close to 300,000, though some have said that the real impact is closer probably to 400,000. And at least 19,000 deaths in the country. So we do have a challenge ahead of us. It's kind of it also is an opportunity. It's made palliative care, the need for palliative care and the importance of palliative care more visible. People don't like to think about death and dying, and we'll talk about death anxiety in a moment, but we have an opportunity here to show why hospice and palliative care are essential to the response to the COVID pandemic. Most of the time we wouldn't think of that, but because we're associated with chronic and non-communicable disease, but these kinds of mass illnesses that cause suffering and dying do respond to palliative care. So we're going to talk about why it's important. We're going to talk a bit about death anxiety, which has gotten worse due to the pandemic. We're going to talk a lot about denial and coping, and also a good amount about grief and how the pandemic is affecting how people grieve globally. So why is palliative care part of the response to this pandemic? Well, for a number of important reasons. First off, through a report that we all put together for the Lancet, a Lancet Commission on Palliative Care and Pain Relief, we know that what's a signal for the need for palliative care is what we're calling now serious health-related suffering. So anytime we have a situation where there is a high degree of suffering, there's a need for palliative care, for symptom management. In particular with COVID, dyspnea or shortness of breath or breathlessness is a prominent symptom, along with cough, pain, secretions, anxiety, restlessness, agitation, delirium. And those conditions, those symptoms require both pharmacologic as well as non-pharmacologic interventions and treatments. And that's something that the palliative care body of knowledge is prepared to respond to more effectively than general medical practice. For instance, most of our medical colleagues don't use morphine. Maybe they'll use some for pain, but very rarely will physicians prescribe opioids for breathlessness. However, it is the most effective treatment we have to manage breathlessness. It's paradoxical because there is the possibility of respiratory depression from high doses of morphine and other opioids, but on very small doses, it's incredibly effective in removing that fear and that sense of you can't get your breath. We also have a skill set in effective communication, how to break bad news, how to help people identify and understand their goals for care, how to help people with making ethical treatment decisions about serious illness, and skills in counseling and support for our patients and families. We are often brought in when there is a need for ethical decision making around discontinuation of treatment or choices. And in COVID, particularly, this decision about whether to go on a ventilator or not has become a kind of key issue. So we're seeing our colleagues in critical care medicine and other fields, pulmonology, etc., calling on palliative care professionals to do consults and to provide support both to the healthcare professionals who are really suffering and struggling themselves, as well as to the patients and families that are facing COVID. And for those where we're unable to succeed, of course, we want all COVID patients to recover from their illness, but we can see, the enormous numbers of people who are not. So making sure that those patients are getting good end-of-life care is critically important. And further into this talk, we'll talk quite a bit about grief and bereavement support. We've actually prepared briefing notes, including one on grief and bereavement and COVID-19 that you're welcome to access through our website, which is www.thewhpca.org. There's a special section on our website for these briefing notes and webinars that we're doing. So, what about death anxiety? Well, it's normal to be fearful and anxious about dying, your own death, personal death. It's not a disorder, a mental disorder, unless it gets to such a degree that it becomes an all-consuming phobic kind of reaction to death. And we know that some people can have severe death anxiety or thanatophobia, which is intense fear that is, if it gets in the way of relationships, that arises whenever anyone thinks about the possibility of their own death or dying, and lasts more than 6 months. Oftentimes, anxiety, of course, is a prominent feature as well as depression. And necrophobia is the general fear of anything to do with death at all. In some ways, though, I hate to pathologize things. This isn't, helpful many times. But in our societies, there's a generalized fear of anything to do with death, which has been one of the things that's really held back the development of palliative care globally and hospice care. Because if people view it as being associated with dying, there's an avoidance of palliative care, oftentimes until very near the end of life for patients. Death anxiety is also affected by security and attachment. And we'll talk about that a little further when we get into some of the theoretical issues. But attachment security is fundamental to managing death anxiety. If one has weak sense of attachment or too strong a sense of attachment, these can interfere with coping with death anxiety and with death in general. And so it's important that we have close connections with others, that we have the capacity to have close, to receive and to give support to others. Well, the more isolated people are, the more anxious there is, the more possibility for anxiety there is. And the things that lead to poor quality of death and dying are not planning ahead for what's inevitable, poor management of symptoms, and lack of support. So we know all those things are critical to good end-of-life care. And we want to help our societies in some ways to become less fearful about death and dying and bereavement. So we'll spend a little bit of time on denial, because underlying death anxiety is this notion about denial, though there's a lot of misunderstanding of what, when we say a person's in denial, it's a derogatory kind of term. So we're going to talk about some of the theories behind this concept of coping or dysfunctional coping. We're going to talk about the difference between denial, that's what we call interpsychic versus interpersonal. And we're going to talk a little bit about the social aspects of denial. Do whole societies deny, or is this really a psychological phenomenon that is for different people? And we know, for instance, that in Mexico, the celebration of the Day of the Dead is a way of, if you will, counteracting death anxiety and helping people ritualize and bring the concept of death and dying into the culture in a way that is playful and I think is a healthy way. I don't know if any of you have seen the movie Coco, but that's another example of a very nicely integrated concept of how we deal with death in our cultures. So this idea about denial actually began a long time ago with Sigmund Freud and his daughter Anna Freud, who talked about they actually used the term disavowal. Freud was treating actually two patients who had lost their fathers, and he called it disavowal, but he thought it was a psychotic defense. He thought that anyone who denied the reality of the situation, in this case, the death of a parent, was actually experiencing psychotic symptoms due to intrapsychic conflict. But after many years passed, and I think partly due to his daughter Anna Freud's work, it was more viewed as not so much a psychotic defense, but more of a neurotic defense. Though we'll talk more about that. In many ways, denial can be seen as both positive and negative. It can be an adaptive coping process as well as a maladaptive coping process. And of course, Elisabeth Kübler-Ross, popularized the term denial as a sort of initial reaction to the knowledge of impending death in the stages that she talked about. She called it a psychic shock absorber. What it did was it basically allowed you some space and time to muster more adaptive coping mechanisms, and just to give you some space to be able to do that. And then that was replaced with other kinds of coping. Avery Weissman, who wrote on dying and denying, you can think of it as a process of three different sort of steps. When someone's told they have a terminal illness, many times the reaction is, no, there must have been a mistake. Somebody's test results got mixed up, or it can't possibly be me. So that's a sort of first order denial of the reality at all of the situation. After some time, that's replaced by a kind of, the reaction is, well, yeah, I've got cancer, but it's no big deal. I'm going to be okay. I'll get well. And then when the disease progresses, it's replaced sometimes by a third order denial or refusal. Yeah, I've got cancer. It's a problem. I'm dealing with it, but it's not. I'm not going to die from it. It's not going to kill me. And that was Avery Weissman's view of the progression that people go through. Thomas Hackett, another theorist during this time, was also importantly raising the fact that denial actually functions in the social sphere, that it's about relationships with people more than it is an intrapsychic inability to cope with a harmful or painful reality. And Richard Lazarus, who is a famous theorist on stress and coping, did say, well, it depends on the circumstances, the timing, and how pervasive the denial is. He understood this concept of cognitive appraisal, and how someone deals with a problem, an external threat that's coming to them. They either change they either try to problem solve the situation and fix it, and when that doesn't work, they then have to change how they're emotionally reacting to the illness. And we see this in situations where people have a diagnosis of a severe life-threatening illness, that they'll try to get the treatment first and try to get cured, but then they have to use emotion to change and focus on coping with it, using it, changing your own emotional reaction. But what we think of as denial, we think of it as this sort of, as Freud did, this sort of an inability to accept reality. It may not be what we think it is. And sometimes I'm in denial and I like it. So in psychotherapy, we have all, we were all, originally trained that we shouldn't challenge defenses of the clients we work with, that we should just observe and accept, whatever defenses people were using. But now what we're thinking is that denial is most commonly used in the service of preserving important interpersonal relationships with the people we love. And the fear is, underneath that, is that if we talk openly about how sick we are, that we'll scare people away, that they'll desert us. And the last thing we want is to be abandoned in a time when we're facing a serious illness. But it's unfortunately the problem that people who don't talk about their illness frankly and openly, people then become more distant. And it's more likely that what you're doing to try to solve the problem is actually making it worse. So we just have to, meet people where they are. We'll talk a bit more about that when we see someone who appears to be not dealing with the reality of their situation. This is some research I did actually quite a long time ago, but I think it's still relevant today, which is we did a random control trial, a small random control trial, looking at people who appear to use denial like coping mechanisms. And what we're trying to do is understand, when we in palliative care have patients that are having trouble accepting the reality of their situation, we try to help them we try to help them to look at what the interpersonal aspects are. We use some sensitive interventions. And in this study, we did a kind of typical intervention that we do when we first meet someone, when they're referred to a hospice. And we did a pre-test, post-test model, and discovered that the people who, the vast majority of people were not impoverished in terms of their coping ability internally. It was about their interpersonal relationships. And when we did, those who got the intervention, actually denial decreased. And in the control group, we had people not getting the intervention, just the pre and the post test. And rather strikingly, those people got much more anxious because no one was talking to them. It's kind of a parallel to what happens if you go see your physician and they're telling you, they're not telling you anything about what's wrong with you, but yet there's something seriously wrong with you. You get more anxious versus someone who's telling you what's going on. This patient won't admit he has a problem and won't even admit he's the patient. These are two men on the sidewalk, one asking for help and won't admit he needs help. So how do we intervene with people when it appears they're using denial-like coping? As we said, we have to meet the person where they are. We want to first understand what they know about their condition. Oftentimes when we ask someone what they know, they oftentimes, even though they've not been told their diagnosis or prognosis, they're able to say, yes, I know what my condition is. I know how serious it is. Many times people are surrounded by friends and family who just tell them that they have to just be positive and think positively. Don't even for a moment think that you could be dying or be seriously ill from this illness. And there's underneath that is a kind of trivialization of their distress. And the problem is that if you actually have that much control over your condition, well, then maybe it was your responsibility, that you're responsible for actually causing your illness, which is not healthy thinking. So we encounter frequently in our work what we call the conspiracy of silence, which is when family asks the physician or clinicians not to tell the patient they have their diagnosis. And this is done by families who want to protect the person and are afraid that that person will become depressed and die sooner or become ill, even though evidence is that people who are told, or people who are told their condition, their diagnosis and prognosis, have an initial emotional reaction, but actually cope better in the longer term. And there's no difference in survival between people who are told and people who are not told their prognosis and diagnosis. So with this conspiracy of silence, I'm going to show you just a short little 2-minute clip that illustrates how this works. Bear with us for a second.
I'm Dr. Lammerton. Dr. McTaggart asked me to see Mrs. Walker.
Yes, it's nice. You could come in. You do know she doesn't know she's got cancer, don't she?
Yes.
So you won't say anything.
I won't say anything that she's not ready to hear.
I won't say anything she's not ready to hear. Is when she asks him not to tell her.
Oh, hello, Mrs. Walker. Nice to see you. How are you feeling?
She's a bit better today.
Yes.
She starts to answer for the patient.
Oh, I think I'm too dry now.
Really? Yeah, I have the same trouble in this weather. It would be awfully nice to have a cup of tea.
Yes, okay.
Thanks very much. Tell me about this pain that you've been troubled by.
Oh, it's in the bed.
Yes.
Let's
Let's have a look.
have
I expect all doctors have had to share in a conspiracy of silence between patient and relative. This patient has had a mastectomy, radiotherapy, and has lost 2 stones in weight. It would be surprising if she didn't have a pretty clear idea of the seriousness of her condition. What makes it worse?
It seems to be worse to have to try and move around.
Worse than movement. I see.
Yeah.
I see you've had radiotherapy there. What was that for?
Cancer, haven't I?
Oh, yes. How was
So she says she understands she has cancer.
Guess when the doctor stopped answering my questions.
I see. And how long has that been? 7 weeks?
6 weeks.
Oh, lovely. Thank you very much. Do you know what your sister's just told me? What? That she has cancer and that she's known for 5 or 6 weeks.
She knows she's had cancer for 6 weeks.
Well, I must say, I'm relieved in a way. It's been such a worry. I didn't know what to say to her.
No, it's a lot easier if you can talk about it, isn't it? Breaking the silence in this way removes a lot of stress from patient and relative, and will avoid a lot of guilt and anxiety for the bereaved later on. This is bound to make the doctor's job easier in managing the patient's home care.
Often just sit after meals.
What about the valleys?
So we see in this clip how skillfully Dr. Lammerton was able to overcome the conspiracy of silence without getting in conflict with a family member. And he's made some, I think, really important points about why it's important for the silence to be broken, so that there's an opportunity for communication between these two sisters. As she faces the end of life, it's critically important that she have the support from her sister, and that there be an opportunity for anything that needs to be done in terms of unfinished business, closure, saying goodbye, etc. So one way to think about this in terms of interpsychic, we think that, I don't know, probably certainly less than 10% of people have such weak inner strength that they're unable to cope with a harsh reality. The vast majority of people, it's more about their relationships is why they're not talking openly about their illness. But it's on a continuum, and so we have to pace our interventions. We can't, one of the mistakes that people make that I've seen in working in hospice and palliative care for almost 45 years now, is people who are kind of new to the field think that the patient has to deal with their, the reality of their condition. They're dying. They have to accept that they're dying. They have to be, acknowledging it, and that's, not helpful and can be sometimes quite harmful, because people need, as we've seen before, time to be able to develop more adaptive coping, and they need support. And so, they're moving from, more to the right on this sort of scale. And as they do, then we can increase our interventions, but we don't want to start off just hitting people over the head. It's just not helpful. We just, really have to, as Dr. Lamberton did, ask her, well, what do you know? What do you think's going on? And then, go from there. I'll share with you a case that illustrates this. This was a 45-year-old engineer by the name of John, who was referred to us because he had metastatic melanoma and very advanced melanoma, and he was having difficulty getting out of bed by himself. His wife was very concerned. They had 2 young daughters, and she wanted to try to help him to talk about his illness and say goodbye to his 2 daughters, because she knew he had probably weeks to live at the point when we got involved. John was a person who was a very logical thinker as an engineer. They had gone for an entire year. He took the family on throughout the Caribbean. They got a sailboat, and they lived on the boat, traveling from island to island. And this, probably was partly why he developed melanoma, was so much exposure to the sun during that trip. But when he came back, he joined a wellness center, and kind of, really solidly bought into this idea that, positive thinking, that he had to stay very positive so that he would survive the illness. And particularly in those days, metastatic melanoma was really untreatable. And so what we did was, when I first met him, I asked him, what do you think will happen with you? And he said, I'll be fine. I'm going to be okay. I just have to keep, this sort of positive view of things and healing myself. And, but it was, pretty clear that he was far along. I didn't challenge him in that first encounter, but just began to work with him. And we brought in actually the head of the wellness center to talk with him and kind of give him permission to do what we do, which is that, the idea that it's one or the other, that you can't hold both realities at the same time, is not therapeutic. So we want people to hope for improvement in their condition, or maybe cure, at the same time facing the reality that they very well might not survive this illness, and they have to do some things to prepare for that. And so we were just trying to get him to move along that continuum a little more. He didn't ever actually make it to the other side. He got partway. He was able to say goodbye to his daughters and his wife, but in his own way, in kind of symbolic language. And after about 2.5 weeks, he passed away at home, died in his bed, but he was kept comfortable, and we supported his family afterwards. And I think as Dr. Lamberton alluded to, it's when you're able to talk with each other about the reality of the situation, you're more able to, the bereavement period is easier to navigate. There's less regrets and less fear or less guilt around the care of the person. So yeah, hospice is a difficult decision for people to join or to come into a hospice program. It's kind of it's actually kind of a ritual for in our society, at least. To become a hospice patient is a kind of ritual that creates an opportunity to acknowledge the fact that illness is advancing and that death may be near, but that support is needed to get through that process. So you all, I think, probably are familiar with the idea of the 5 stages that Elisabeth Kübler-Ross taught all of us. She taught us a great deal, actually, about how patients respond to their illnesses, and she learned most everything she taught from patients themselves. So she shared on Death and Dying in 1969 this idea of common reactions that people have when they're faced with a life-limiting, life-threatening illness. And she really was very clear in her writing, I think, about that dying isn't about stages. That, in fact, we think nowadays that dying isn't, there are no stages really to go through. And this notion is sometimes not helpful, to think that people have to go through in some sort of rigid, prescriptive fashion, denial to acceptance continuum. Those are just common reactions. Some people only have one. Some people, start at acceptance to begin with. I mean, though acceptance is not resignation. It's not just giving up and being helpless. It's more about embracing what's next, and also feeling that your life is complete, that you have understood what the meaning was around your life, why you were here, and what your personal meaning was in being here. So she taught us about compassion. Really, Elisabeth opened a door in society's consciousness to be able to talk about death and dying and bereavement. It was taboo to do that before she opened that door for us, and so that was a huge accomplishment that really helped society move forward, and in terms of changing norms and changing attitudes, and ultimately becoming healthier psychologically by doing so. So let's move on to talk a bit about grief. We have a number of theories we'll talk about. We'll talk a little bit about anticipatory grief. We'll talk about the new proposal for grief to be included as a disorder, a mental disorder, by the American Psychiatric Association. And then talk about some of the guidelines we've developed for helping people who are in a situation where they're grieving for family members that they couldn't see when they were sick and couldn't even attend their funeral, and how that impacts some of our patients and families. So there's 2 big theories about grief and loss that we look at that help us understand grief and loss. Bowlby's original theories about attachment, and a newer model that is called the dual process model that was developed by Maggie Strube and Hank Schutt and Simon Rubin in Israel. So we talked about death anxiety and attachment, and the importance of attachment, and having the ability to receive support and be attached to others. And we kind of think about attachments as being either secure or insecure. Insecure attachments are attachments that are too strong. That's when your parental figures are just so strong in your life that there are dependency issues that get created as you become an adult. And how it affects grief is there is more of a tendency for death anxiety and for grief to be prolonged, because you can't stop grieving. Then if the attachments are too weak, there's an inability to form relationships and to express grief. So it's kind of like the Goldilocks theory, when we talk about secure attachments, it's that, it's the not too strong, not too weak, it's just right, kind of level of sense of attachment. We also understood from the dual process model that what happens with people is that we live our lives, if we're healthy in our everyday experience after a death, we're kind of going back and forth between having memories of the person who's died, and sadness and grief, and also at the same time having to move on with attending to life's work, and having to change your role as a spouse or whatever relationship you had with the deceased, and that the oscillation between those two is a healthy process. And where it breaks down is when you get stuck on one side or the other and you can't go back and forth. So you're stuck if you're in the too strong side. So this is how it relates to the attachment theory. You're stuck in your grief and you can't get out of it, and you're just grieving all the time, and you can't attend to the daily life stuff. Or conversely, if you never can grieve and you're stuck in just the day-to-day details and unable to oscillate back and forth. So I think those two ideas have helped us understand that it is about the relationships we have with people, and that people don't go through stereotypical stages of grief. There was a book written a number of years ago by Dennis Class and Phyllis Silverman called Continuing Bonds, which the idea was that we had to decathect or get that person who died out of our emotional lives. And we know that human beings aren't like that people, continue to have emotional connections to those who die after they're dead. And so that, this was putting an expectation on people that was not helpful, not therapeutic, and that we have continuing bonds with people after someone dies. And also there's a body of thinking that, people are very resilient, and most people, get through grief without any big problem. That's George Bonanno's work. And there's truth to that. But we also kind of look at, some of the early work that Elisabeth Kübler-Ross and other theorists did, that you have to empty your pool of pain. Elisabeth would tell us that all the time. She'd get, a mattress and a rubber hose and have people beating on the mattress to get in touch with their pain, get that pain out of them. And then you have these other theorists who think, well, you don't really have to deal with grief. Some people never grieve and it's okay. It's not a requirement that you have to grieve. And of course, relationships are all different. So we may grieve more for one person in our life more than another. We sort of now think about the middle path, which is that sort of idea about oscillation back and forth, flexible coping. It affects you. It's not a medical condition. It's part of life. It's part of the human experience, and that we don't want to get stuck in one side or the other. Rodrigo asked me to talk a little bit about anticipatory grief. And of course, we know that people, when you're in a situation where a loved one has a condition that is likely to cause them to die, versus somebody who has a sudden death in an automobile accident, for instance, that there's a process of beginning to experience grief before the death actually occurs. Intense concern and sadness, anger, fear, sometimes rehearsal in your head. You're imagining, oh God, what's going to happen when he or she dies, versus the person themselves who is dying, who has preparatory grief, where they're preparing themselves for the end of their own life, and look, wherein there are opportunities for growth, closure, forgiveness, and the ability to say goodbye. Those are the most important things for dying patients, is to ask for forgiveness, to forgive others, to tell people you love them, and to be able to say goodbye as being key things when you're facing death, to do with those that are part of your emotional life and those you love. With COVID, this has thrown everything up kind of into, created kind of a mess in terms of, we're all living in these sort of, lockdown situations where things just don't seem normal. I mean, I go to the grocery store every 3 days wearing a mask, gloves, such, glasses, and you look around at everybody in the store, the few people that are in the store are all wearing masks. And if any of you remember from the 60s, this show, The Twilight Zone, it almost feels like you're in some alternate reality that, isn't real somehow. So you get this sense of that things aren't real, that it's hard to connect with other people. We're compensating for that a lot, I think, by using technology in ways that we couldn't in the past. But everyone's a bit fearful, what's going to happen? And there, in psychology, we have this idea about intermittent negative reinforcement, or positive reinforcement, which is highly motivating. So what we have is a situation where we've got an illness that, for reasons no one can explain, kills people, and other people have a cold or a minor illness or don't even have any symptoms. And no one knows why some people are progressing and dying, we know that older people are more vulnerable, those with pre-existing conditions are more vulnerable, but we know that children now are dying from COVID, that we have young people, middle-aged people, all also experiencing pretty frightening symptoms and no one knows, it's like, just don't know. So you're isolated, you're kind of hyper-vigilant, worrying about it. You don't feel in control. People often imagine the worst. We're all kind of avoiding each other. Who knows if we'll be shaking hands in the future with people or hugging. And we're all stressed out and exhausted in the process. So, we have to do more to connect with others and take care of ourselves, do basic things like eating well and exercising and to some extent, making sure we're not, that we love ourselves too, that we take care of ourselves and we feel good about ourselves. So there has been a proposal to establish what is called prolonged grief disorder. It's been a debate that's been going on for about 10 years in the psychiatric and psychological communities. And it's important we understand that grief is not a mental illness, that grief is a normal human experience, and that the vast majority of people who experience a death will get through it. It's just part of the normal part of the human experience. However, there are a small number of people who seem to have a very difficult time getting over grief and loss. It's debatable as to how many, what percentage there is. And in our work over the decades in doing bereavement follow-up with all of the families that we serve in hospice and palliative care, we follow people for a full year. Most of the people do fine with some psychoeducation, talking about what grief is, normalizing some of the symptoms that people are frightened by, allowing them to tell the story of what happened over and over again, which then integrates it into their sense of the life story that they have for themselves and the people they love. And then there's some people, so they just need a minimal amount of support and education. There's also a group of people who are, they're feeling pain, and it's, it's a difficult time and they need support, but they get over the the loss. And then there's a small group of maybe 5 to 10%, I think, of people who really have a very hard time specifically around the death. And it goes back to the theories about attachment, too strong attachment, and inability to oscillate back and forth between being stuck in grief and also getting on with life. And for those people, we've been concerned because they have no, if they go to treatment and they really often need to see someone to help them, someone competent in dealing with grief and loss issues, they have to pay out of pocket. And of course, then for the poor, they're unable to get that care because they don't have the resources to do it. So they oftentimes have a lot of depression, anxiety, and health issues that emerge. So having this included at least is a way for those people to get the support they need, though at the risk of creating a perception that grief is a pathology. And the last thing we want to see happen is that we start seeing commercials on TV for, grief away medicine that, people are, instead of actually getting support to work through and get the grief and be able to do the tasks of mourning and get on with creating a new life that includes the person but in a new way in their emotional life. So here's the criteria for prolonged grief disorder, which is that it has to be at least 12 months. So if someone is experiencing suffering because of a death, most people, the vast majority of people, by 6 months, usually they're not experiencing that sort of intense emotion. But certainly by after a year, if it's still going on, then it's potentially a cause of clinical concern. The grief response has to include just this sense of, intense yearning and longing for the person that died, and preoccupation with their memory, and has to be there pretty much on a daily basis. Then this is the sort of the key part of any of the DSM criteria, which is there's a list of symptoms that you have to have at least some of, in this case, 3 of these to significant degree every day or most days, and identity disruption. So it's a marked sense of disbelief about the death, avoidance of reminders that the person is dead, intense emotional pain related to the death, difficulty moving on with life, engaging with friends, pursuing interests, planning for the future, emotional numbness, a feeling that life is meaningless, and an intense feeling of loneliness, feeling alone or detached from others. This has to impair social, occupational, or other important areas of functioning or education. The duration of the reaction would exceed what would be normal from a social and cultural and religious context. And symptoms are not better explained by another disorder like major depressive disorder, for instance. So another case, just briefly, and we were going to be over, we'll go to question and answer in about 5 or 6 minutes. Trudy was a patient of, the wife of a patient of ours who died of pancreatic cancer in our hospice, in the hospice I worked in at that time. She was a 63-year-old woman who was a professional social worker who came into therapy because she was at that other end of not being able to express her grief. She felt numb, but not saddened by the death, but had been very close to her husband, been married for a long, long time, had dependency issues and issues with her father. And what happened to her was when she was 19, Fred, her husband, saved her. He basically dated and then married her, and then she was able to leave her parents' home. And we discovered in the course of therapy that that actually her father had sexually abused her when she was a teenager, and that this was a kind of way for her to escape those abusive circumstances. When her father died, she never could grieve for him, and now she wasn't able to grieve for Fred. And so we went through just the whole process of psychotherapy with her to help her, because this is a situation where, you know, she had attachment issues growing up, but also was kind of frozen in her emotional development as an adolescent. And so we had to work on, you know, the issues that we do in therapy of helping a person become a person, and first establishing a sense of feeling safe, then feeling more in control of her own emotions, being able to have real relationships and connections with others, and then a sense of personal identity in her life. So we're talking about grief during the time of COVID, and we have a working group that includes a number of people: Bill Warden, Dale Larson from Santa Clara University. Bill, of course, wrote Grief Counseling and Grief Therapy, the famous book. Jenny Hunt, a therapist from Africa. Diane Gray, who's was vice president of the Elisabeth Kübler-Ross Foundation, or president of it for many years, with Ken, myself, and then a social worker who was our head of the bereavement section for the National Hospice and Palliative Care Organization, where I used to work. So this is available, as I said, on our website. It's a briefing note for helping family members who can't visit sick relatives or attend funerals. We talk about the current situation and why, because of contagion, people are unable to participate in the usual rituals that people have, and what we can do about that. So there's a lot of physical and social isolation that happens to the patient and to the family. The inability to care, to actually provide hands-on care for a loved one, limited communication, delayed information, and guilt and remorse. So we have a lot of impairment in just what normally happens in the process of caring for someone with a serious illness and the death afterwards. We see people experiencing what we're calling traumatic grief now, and some post-traumatic stress disorder, particularly for health professionals. Anger at the institutions, as we said before, a sense this is not real. Frustrations, breakdowns of social networks, and being unable to explain to others what happened. These briefing notes are specifically directed toward health professionals. So we're trying to mitigate some of these factors to help minimize the negative impacts in terms of grief and loss afterwards, and encouraging communication, helping families with the funeral process, and helping them participate even remotely sometimes. Compassionate listening, curious inquiry, creating safety and expression of emotions, helping people tell the story of what happened with the death, repeatedly, and emphasizing how unique this is, this situation is to normal. I'm going to leave you with a quote from one of my favorite authors, Lisa Marburg Goodman. The more complete one's life is, the more one's creative capacities are fulfilled, the less one fears death. People are not afraid of death so much as they are incompleteness in their lives. So I hope for you completeness in your life. This is a picture of me with Elisabeth. I'm the one without the turban. Back in this was about 1977, I think, when we were having some time with Elisabeth and doing training with our hospice workers back in those days. So I want to thank you very much for your attention today. We're ending right on time, and hopefully now we're going to have a chance for some questions and answers. And I hope you're all well where you are, and taking good care of yourselves. Thank you.
Oh, great, Stephen. Thank you really much. It was wonderful. Okay, so let me check. Daniela Chet said, thank you very much for hearing you and learn from you and your experience. A friend of us, Silvana Aquino, asked you to explain how we can take care of healthcare providers who are losing their friends and their colleagues.
Yeah, I think that reminds me of the days when we were facing the HIV pandemic and we were having the experience of multiple loss upon loss. Those were dark days back in the early 80s. And I was in San Francisco at the time, at Hospice of San Francisco, and we were kind of at the epicenter of that. And, you know, the same principles, I think, apply as did then, as we, you know, experience both the loss of our patients and the loss of friends and family members who are being affected by COVID. And the same principles apply, I think, that we have to grieve these losses. Can't just bury them. We have to experience the grief. We have to accept support from those around us. We have to take care of ourselves. We've tried all kinds of different ways, you know, working in hospice and palliative care and seeing thousands of people die. You have to develop a kind of what we call balanced empathy, where, you know, you don't get too overly involved with the patient and family that you're caring for, but you get involved enough that you are being a real person with that and not a cold professional. But if you get too involved, then you get burned, and that's when oftentimes we see burnout happening. But, you know, the other things we spoke about of, you know, getting enough sleep, exercising regularly, you know, accepting and giving support to others, and understanding that, you know, this is like it was for HIV back in those days before antiretrovirals, that this too shall pass.
Perfect, Stephen. Thank you. Bianca asked if you can talk a little more about alternative strategies and resources for providing closure for families unable to be with the body or at the funeral.
Great question. Yeah. So what a lot of our colleagues are doing is really trying to use telemedicine capacities or telehealth capacities. I mean, simply FaceTime, you know, having virtual funerals. Some people are even, you know, delaying having memorials until it's, you know, we're in a situation socially where we're able to congregate with other people, being together. But the best we can do now is to, you know, to create the same kind of ritual that we would have if someone dies and we're gathered together, but doing it, I mean, using Zoom like we're doing today, using FaceTime or Skype or any of the other vehicles we have to memorialize the person who died, to talk about what impact they had on our lives, to share stories and memories, to talk about, you know, the good, the bad, the ugly, all of it. It's not the same thing as being together physically in person. It's a substitute. It's a kind of a palliative, if you will, until we can all get together again. And I think a lot of people will find that there's something that you need to do at, you know, at the time of the death, and maybe, you know, creating sort of online memorial that continues on. But I think a lot of people who've experienced the death, once the all clear happens, whenever that is, if that ever happens, that we're going to see people redoing a lot of these rituals together, and I think that'll be healthy. But right now, the best we can do is just to, you know, to create a kind of virtual memorial and grieving process. And then, you know, if a lot of people are alone, and that makes it doubly hard. If there's someone you're sheltering with or you're quarantining with, if you will, you know, usually that's someone who probably was a family member or someone who you can share those same experiences with in person. Anyway, that's about the best we can do at the moment. And every rituals can be quite variable in terms of, you know, how they're done, depending on the values of the person who died and what they valued. So be creative.
Wonderful, wonderful. Thank you, Stephen. Thais Pagliano asked you to explain a little bit more about denial and how to deal with denial with the terminally ill patient, and how to understand better if it's a healthy process, and in terms of intensity and frequency.
Yeah. Well, first, as we did in the presentation, we want to make some distinction about whether or not this person just doesn't have the inner resources to cope with reality, or is this more of an interpersonal inability to talk openly about the illness, or where are they on that continuum, if you will? And as Elisabeth said, you know, the psychic shock absorber. So, you know, it's very common for people, their first reaction is often denial. Even the healthiest of us may have that reaction, particularly around a sudden death or an illness, sudden illness. So what you're looking for is, first of all, you want to meet them where they are. You want to ask them what they think is happening. If you're talking about patients that have been diagnosed with a serious illness, advanced illness, you want to kind of just hear what their perception is, what they think is going on. Don't assume anything right away. Just find out from them what their perception is, what they're going through, what they think's happening. And most of the time, as we saw in the tape, that opens the door to, you know, more frank, you know, conversation about it. People, on the interpersonal side. First of all, Elisabeth had another axiom that she taught us. One was that if you tell somebody that they are, say, seriously ill, after the third time, stop telling them. If they don't believe it and they won't listen to you, that's probably a signal that that's someone who's lacking inner resources to cope with the illness. But for the vast majority of people who it's more about their relationships with other people, it's either they're afraid they're going to harm someone if they talk openly about it, or that other people will abandon them if they talk openly about it, and sometimes they just don't want, they can't deal with the emotional reactions that happen when you talk frankly. This is the big problem with physicians not telling patients the truth about their condition, is that they can't deal with the patient's emotional responses. They just never were trained to, and you know, many times in the course of training in medicine, people sacrifice a certain amount of their social intelligence to, you know, become such a strong scientist, and they're spending all their time doing that, but they become somewhat stunted in their emotional intelligence. That's a gross generalization. You know, many physicians are exceptionally good at this stuff, and we have some really good training tools around teaching people how to communicate, physicians how to communicate more effectively. But if you think that this person's, you know, on the interpersonal side, just try to walk with them, be with them, help them, keep the door open for discussion. Try to do that thing we talked about of, it's okay, give them permission that they can deal with the reality of the situation without giving up hope. Because that's what people are fearful about, is that if they, for 1 minute, accept that they're, you know, they're really seriously ill and going to die, that they won't, that then their hope goes away entirely. And that is a false assumption, because, you know, especially nowadays with treatment, you know, we know people who, you know, were given 6 months to live, who are live alive 5 years, 10 years later sometimes. We don't know when people are going to die, actually. Our ability to prognosticate is poor. Physicians, for the most part, overestimate prognoses. But everyone's different, and we've seen some extraordinary things happen to people. So we can't say to anyone with certainty, I know you're going to die next week at 5 o'clock or Tuesday. We've been fooled many times, and it's hard to take away. We don't want to take away hope from people anyway, and you have to help them redefine what hope is, so that maybe it's hope for making it to a graduation ceremony or the birth of a grandchild or something like that. Okay.
Wonderful, my friend. Thank you. And maybe the last question, or maybe 2 or 3. Okay. Okay. So how do you think the pandemic will change our perspective on death and dying?
Great question. Well, I think it's already changed to some extent, because it's caused society to come face to face with the reality that that we're all going to die. And I think we have this magical thinking. We know people die. We know other people die, but we don't apply it to ourselves. We, really back there somewhere, we have this sort of sneaky feeling that, yeah, but not me. It's not going to happen to me. But then when you see, young people just, sort of randomly, all of a sudden they have kidney failure, or they have strokes, or they have this or that, and you go, holy moly, it's, you have this sort of plan in your head. Well, I'm going to live to a certain, like 90 or whatever age you've picked out, and all of a sudden, maybe that ain't going to happen. Maybe you're going to get the COVID and you're going to die. So it's really created, forced people to confront, to some extent, the reality that they, that we're all mortal, and so that is perhaps helpful. I think people have. We're beginning to see a greater appreciation for palliative care as part of the response. There is a bit of a danger that we don't want palliative care to be viewed as just end-of-life care. And there's a bit of a danger in that, we'll bring in the palliative care consult when they're on a ventilator and they're, their stats are dropping or whatever. We want to be understood as people who accompany others on the journey of serious advanced illness, and help relieve, not eliminate suffering, because we can't eliminate all suffering, but we can relieve it, and we can make it bearable for people, and we can help not just to prevent problems from happening that we know are going to happen, or to treat problems that are currently facing us, but also to promote growth and some sense of wholeness and wellness at the end of life. Those things, it's not just about treatment; it's prevention and promotion as well. And that's one of the things that Elisabeth really taught us, was that we're here to promote growth, to help people. Take a bad situation and turn it into something that you can learn from and you can grow from in some way.
Perfect. Just more 2 questions, okay?
Okay.
Okay. Please, in Brazil, we see already the most deaths are happening among the poorest. Yes, and we are facing this reality in our compassionate community in Rocinha. How do you see the grieving process among people that feel usually invisible socially?
Well, that's an interesting question. We do quite a bit of work in, all of our work is in low and middle income countries, because we think, palliative care is fine in high income countries, they have to take care of themselves. But we work in Bangladesh, we work in Ethiopia, we work in Kenya, we work in South Africa. and places where, you know, there is a lot of poverty, and we are very much strongly in the mode of helping develop compassionate communities. In fact, we're working in a slum community in Dhaka in Bangladesh, and it's not called the Palliative Care Program. It's called Compassionate Corral. And the palliative care assistants are the workers. They're not the, we have physicians and nurses and mental health professionals, but the frontline workers are all community health workers that we call palliative care assistants in a compassionate community. And it's really striking to me, having spent some time in these places, how connected the community is to each other, in particularly slum communities and poor communities. You know, in high income countries, you know, everyone's house is separated, and they, you know, maybe they have gates, they have, you know, they don't know their neighbors, they've never even met them. And that's very different than, you know, in communities where no one has any resources. So in fact, you see a greater kind of sense of generosity in poor communities than you do in you know, better developed countries. That's a, you know, overgeneralization certainly, but you know, but we know that when we're caring for someone with a serious illness, that there's a web around them of people, and not just family, but neighbors and people who are in, you know, who are in similar circumstances. And we try to do is bolster and enable that compassionate community caregiving network that exists. It just needs to be facilitated. It can be done in high income countries too. You know, just because you have to activate, you have to sort of, because people don't know in high income countries. In low income countries, when someone's pregnant or has cancer, everybody knows it very quickly. But in high income countries, it's a little harder to create those networks sometimes. Anyway.
Okay.
One more.
Okay. Yes, the last one.
Okay.
After the pandemic, we are going to face maybe very serious kind of mental health condition. So what's your vision about that? What's your point of view?
Well, first, I wouldn't underestimate the resilience of humanity and, you know, people. We're surprisingly resilient people, creatures. And however, as we said, we're facing very unusual circumstances, and we have that continuum of coping from, you know, very weak ability to cope with anything and collapse. We see this in families when we admit someone to palliative care. Some families can walk on water, they can do everything. Other families just collapse, and you know, and there's, you know, and lots in between that. But we will see probably more post-traumatic stress disorder in the health professions in particular. And again, we saw some very similar things in the early days of HIV in certain places like San Francisco, New York, and other major cities. We have a toolbox of things that help people with post-traumatic stress disorder. That's a whole other topic unto itself. But if you think about it, that's kind of what people are likely to suffer more from than they would otherwise. We should be alert to that. And, you know, it's also, with grief and loss, very important that the social support, the perceived social support, the sense that you feel supported by people who care for you and about you, makes such a huge difference to how people cope with most everything, but particularly this time. We need solidarity. We need to care for each other. We need to love each other and be compassionate with each other. And again, lessons we learned from Elisabeth. So on that note, I thank you all really very much for joining us today, and hope this was useful for you in your work.
Thank you really much, my friend. Thank you really much. As a friend, I say thank you. And I say thank you to all your efforts worldwide And everyone is saying thank you really much. Thank you for the opportunity to learn from you, and thank you really much. And here we are working and we are going to continue. And thank you really much for supporting everybody in Brazil. We talked today with a lot of people from every part of Brazil, so it was very important and very helpful. So really, thank you very much.
You're welcome. Beautiful country, beautiful people. And
okay.
You, there you go.
Okay.
Oh, thank you, Maria, the translator, for.
Yes, thank you, Maria. You did a wonderful job, my dear. Thank you. So, thank you, Stephen.
Bye for now.
Bye for now. Bye-bye.
Adios.